So for our clinic, the Critical Care Recovery Center, we just published our results in American Journal of Nursing in March. We are the first clinic in the United States to show efficacy of having an outpatient clinic model for ICU survivors. We have shown that our patients have improved behavioral symptoms, our patients have improved physical function, our patients have improved cognitive symptoms on a validated monitoring scale. So based on that scale, we have shown improvements in our patients. Now, having said that, we have testimonials from a number of survivors over there who have come across and being able to a spokesperson for the clinic, how the clinic has helped them navigate the healthcare system. So for a physician, the gold standard is a mortality outcome, But when I look at success for for a disorder like this, to me, a success is a patient and the caregiver. If they are happy with the care, if they think that their quality of life has improved, then to me, that would be successful for the program. Unless we achieve that, like all of the healthcare folks, I'm more interested in obviously reducing the rehospitalizations and all the cost utilization, have some improved outcomes regarding their cognition, psychological symptoms. But again, for that you need a large sample size, and having such a small clinic that we have, it would be tough. We have shown some initial results, but to me the most important outcome is what the patients and their caregivers are saying about the service, how they are going to navigate through the healthcare system. Is that service worthwhile for them or not? Well, we are not the only one anymore in the United States. When we started 4 years ago, we were the first clinic to start. Afterwards, Vanderbilt School of Medicine in Nashville, they have started an ICU survivor clinic. There are other clinics that are trying to start. I was just at American Thoracic Society, and we have a session on ICU follow-up clinics. So far there are 3 in the United States, including ours. And then there are many of them that are trying to start the ICU survivor clinics. And actually, I have meetings scheduled for the next 3 weeks with different hospitals to help them how to set up their clinics. So I think this will catch on. I think it's just early in the game. So until unless the magnitude has been realized by intensive care doctors and the local administrators, it will be difficult to generate awareness. Once they know the magnitude of the problem, then I think it would be easy to make a case. The other thing is cost, but there are always innovative ways to defray cost once you set yourself to the task. I think at this time it's just really early in the game, and once there is more awareness, once people realize that before everyone dies, they end up in an intensive care unit, and if they survive, they will end up with the post-intensive care syndrome, and especially with 5 million admissions to United States every year, with millions of ICU survivors coming out with cognitive, behavioral, and physical problems. We have younger folks in the community who would not be contributing to the society for at least 2 years after they stay in the ICU. I think we will reach the point where we need to do something about it. And we are very glad that at Indiana University we started this, so we can at least lead the way to help the rest of the community in the United States and abroad to start the clinics. Well, at this point, what we want to do is to continue with the clinic that we are doing, try to scale it up instead of 1/2 day a week, maybe doing it more so that we can approach more ICU survivors. The second thing we are doing, we are building a mobile arm of the clinic. It's going to be called the Mobile Critical Care Recovery Program. And the purpose of that program will be to use the model of the clinic at the home setting, to develop the care coordinators who can go to home of the patient, assess them, and then they can come back and talk to me, and I can start the protocols over there. And then we can have the patients who need to come to the CCRC come to the CCRC. So that's the second version of the clinic that I'm envisioning right now.